Good afternoon, everyone. This session is ready to begin. The session is sponsored by the Peterson Center on Healthcare. We certainly appreciate their support. Leanne Kandura from Human Services Research Institute, or HSRI, will moderate this session. Leanne, you have the floor.
Thank you, Charles. So good afternoon. I'm Leanne Kandura. I'm the director of the Population Health Team at HSRI. It's my pleasure to be the organizer for this session, using data to contain costs, benchmarking past, present, and future. We have a fantastic slate of presenters who will be sharing their experience on creating dashboards, toolkits, and strategies that highlight the use of data to contain costs. Please feel free throughout the presentation to add Q&As directly into the Zoom chat. We'll be answering some questions after each presentation and then move to the next presentation. Hopefully that will also allow us enough time at the end to have additional questions for all of today's presenters. To kick off today's session, I will introduce Steve Johnson, Vice President with the Lewin Group. Dr. Johnson is a risk adjustment expert with 37 years of experience working with healthcare data, primarily focusing on the analysis of Medicaid data. He has led efforts to develop programming logic to process claims data through risk adjustment algorithms in order to determine plan factors for risk adjusting payment projects. Please welcome Dr. Johnson, who is presenting on improving health plan operational efficiency through business intelligence.
Thank you, Leanne. Today I'm going to give you an overview, as Leanne said, of some of the work we've done with Medicaid plans. And this presentation is more focused towards primarily Medicaid health plans, but also the analytics that we're going to show here are also applicable to ACOs and even for, the Medicaid agency itself, who may, if there is no managed care, they're kind of administering and running and overseeing the care for their members a little bit more closely. So we're going to show you 5 data visualizations that we've built to look at different aspects of health plan performance. And these are all factors where the plans can get directly involved, try to control utilization, improve quality, and impact their bottom line in terms of the performance of the health plan. One of the things that we've found with every one of our health plans and states that we've talked to in Medicaid is the use of ED services. That many states that we've worked with and health plans have commented that ED utilization is kind of going out of control, and they're looking for ways that they can control utilization and control the growth in their costs. So one of the very first dashboards that we ever did for ED utilization was for a client that said, well, my ED utilization is going up rapidly. Where are they going? Where are my members going? So we've built a pretty straightforward view where in the upper porch graph, you can look at each of those circles, and each of those circles represents a hospital, and you can see what's the volume on the y-axis for that hospital and what's the average cost per visit on the x-axis for that hospital. So you see the hospital in the upper right-hand corner has about the highest volume and also the highest average cost. Within the tool, and this tool is built in Tableau, you can select any one of those hospitals, and if you select that, then the bar chart in the middle will filter to show you, well, why are people going to that hospital? Are they going for avoidable care, or are they going for care that's required to be seen in the ED? And what we do is we use the NYU algorithm, the updated version that's been updated with expanded codes and ICD-10 codes to classify visits into these 4 groups. The way the algorithm works, a specific diagnosis code, they might say, well, half the time this service is treatable in a primary care setting, half the time it's required to be seen in the ED. So we've taken those probabilities and we've kind of added a layer of logic on top of that to say what are the characteristics, what's a single bucket that we can put this visit into to avoid kind of splitting it over different categories. So we can easily see which of the visits are, or which of the hospitals are providing a lot of avoidable services, and then from there, you can actually drill down in the lower bottom of the visualization to see members. Each of those circles is a member, so we can pick a hospital and see that this member went to the hospital 30 times or 40 times for avoidable services. We found instances where members have gone to the hospital over 350 times during the year to receive care in the ED. And so that's kind of the starting point, just to understand, you know, what utilization looks like. Charles, do you have a question?
I'm sorry to interrupt you. We're all kind of seeing the backstage, and I'm afraid the audience can't necessarily see your visualization very well. Would you mind if I share the screen for you and you just say next and I'll?
Sure.
Thank you. Give me just a quick moment. I apologize for interrupting.
Okay. You're not seeing the screen at all?
No, we can see it. It's just that we kind of see the backstage view right now. So it'll be a little more clear, I think, this way.
Okay, great. All right, well, next slide. So after that initial screenshot, if you can go to the next slide, Charles, we started to look at utilization by county. So in the map on the left-hand side, you can see kind of a color-coded view of the counties where we have the most hospital utilization, and it's kind of a little hard to see, but in the top of that visualization, there's a filter where you can look at avoidable visits, required visits, and this is focusing on avoidable. So if I look at avoidable visits, I get a table on the right that shows me the counties and the number of avoidable visits and the dollars associated with those avoidable visits in those counties. So I can focus on counties where avoidable visits are higher and maybe the network isn't as big as it needs to be, the primary care network, that members are having trouble receiving services in the community, so they're now going to the ED instead. If I pick a county in that table on the right, then you'll see in the bottom, it's just going to list all the hospitals in that county, show me how many visits they had, how many of those visits were avoidable, and what was the total value of those avoidable visits. Next slide, Charles. So if I pick one of those hospitals, then it's going to take me to a hospital dashboard where I can understand on the left-hand side what are the reasons that people are going to the hospital for avoidable services. So it's coughs, it's colds, it's sore throats, it's earaches. So a lot of routine care that could be seen in a primary care setting. I can kind of see what the trend has been over time in that little graph. I see in the top that there were $3.1 million worth of avoidable care provided in this particular hospital. And then one of the things we do in kind of a heat map in the middle of the right-hand side is look at when people go. Are they going on the weekends? Are they going on the weekdays? We see higher incidence of avoidable services on weekends. And then finally, look at that over time. And we see a lot of seasonality with visits spiking more in the winter time than we see in the summertime. And then finally, in the bottom bar chart, look at how often people are going. So are there those frequent flyers where the health plan or the hospital could reach out to these members and try to divert them to either a primary care office setting or an urgent care clinic, and see what type of intervention they can have with the member to prevent them from going to the ED 20 or more times during the year. Next slide. Hey, the other thing that we've done for our health plan is to, if you go back one slide, please. Okay, is to look at case management, disease management programs, or support their case management, disease management programs. So we've created a visualization where they can kind of drill into their data using filters. That's a common, Tableau functionality to understand if they want to target members for case management, disease management programs, what population can they identify that's small enough that they can accommodate that population with their program. So in this particular view, there's filters on the right-hand side. I've got this filter to look at very high acuity members. I can look at members with multiple comorbid chronic conditions. I can look at members who are duly diagnosed with behavioral health and physical health conditions. And as I apply those filters, I'll see a list in the bottom of the visualization that shows members and what their age, what their coverage is, what their acuity is, and then some basic statistics on their utilization of different services. So that's one way to kind of drill into the data. I also have the ability in this screen to say, well, let me exclude members with cancer, let me exclude members with leukemia or hemophilia to get, or acute chronic renal failure, if I'm not going to put those members in the care management, disease management programs I'm trying to enroll members for. So that offers kind of one approach to get into the data. The next slide is a similar approach for the same purpose. We're here now. We've limited the data to members to enroll in a disease management program where the member has to have a chronic condition. So we're starting off with a subset of members that have a significant condition, and then again can apply the same kind of filters to look at specific types of different chronic conditions, and also look at acuity and other characteristics of the member to get a population, again, in that table on the left, that I can manage. I don't want to identify a population of 10,000 members if I don't have enough care or disease management staff to manage that population, but try to get it down to a level that I feel I can reach out to. And then the third approach, or next slide, please. The third dashboard that we built for one of our health plans is to look at opioid utilization. And this dashboard also kind of gives us the ability to benchmark members and providers in a variety of different ways. This particular dashboard allows me to look at the number of opioid prescriptions that a member received on the x-axis, and then on the y-axis, I can put different choices. So right now, I've got the number of ED visits, and each of the circles is a member. So the horizontal and vertical bars represent the 95th percentile for the number of ED visits and the number of prescriptions that members have. So if I look at those blue dots in the upper right-hand corner, then those are members that are in the top 5 percentile in terms of both prescriptions and ED visits. And we see this pretty commonly in all the data sets that we've looked at in terms of ED visits, that the highest cost opioid users, it's not so much the cost of the drugs themselves, but 60 ED visits, 100 ED visits, where members are going from hospital to hospital to exhibiting some drug-seeking behavior. So from this visualization, you can actually select a member and drill down to a view where you see what ED they went to, what was the diagnosis code, and for those frequent users, we often see strains and pain and just kind of signs and symptoms, not really seeing any significant chronic conditions for those members. We can also see what are the chronic conditions that the members have. Do they, and I should have said that in building this module, we take out members in hospice, we take out members receiving cancer treatment, chemotherapy, and take out members who are long-term residents of nursing homes. So we have an otherwise healthier population in the community. So this gives us the ability to kind of drill into the members and see who are outliers and what are the characteristics of those members, and have similar views where we can do exactly the same thing for providers, looking at their prescribing patterns and control for their provider specialties, so that we're comparing them against their peer group. All right, if we can go to the next slide. Okay, the other view that we've built is the ability of the health plan to kind of evaluate the performance of their providers. And this dashboard was built using all the features of symmetry that we typically build into our provider profile. So it's kind of a provider profile a little bit on steroids, where in the upper left-hand corner we have, how big is their panel, how many members, what's the PMPM, In the right-hand side, what's the prevalence rates for different chronic conditions within their population, and the blue bars and the black bars are what's the total dollar value associated with treating those conditions. Middle bar chart kind of look at, cost per member per month using Medicaid eligibility groups, but apply a risk score for each of the members in each of those eligibility groups to come up with a risk-adjusted PMPM, and then compare that to the provider's peer group to see, controlling for risk. Are they actually more efficient or less efficient than their peers? Bottom left-hand side is the ED utilization, required, avoidable, the categories that we looked at before. And then we've also got, and I don't know if you can actually read this or not, but we have a couple of views where you can look at select quality measures and see what the adherence rate is for that provider's attributable panel to kind of benchmark against the overall adherence rate for the program and other providers in their peer group. And then finally have the ability to do the same thing with one of the features of symmetry, which is episode treatment groups. So you can pick an episode of care, see what the average cost was for episodes overseen by this provider, and compare that to their peer group to see on more, kind of an apples to apples basis, how efficient is that provider. And so lots of different ways to kind of drill into the provider and look at their efficiency. And then finally, on the last slide, just one other example that we've built is a quality dashboard where we use EBM Connect, Evidence-Based Medicine Connect, which is part of Symmetry. It'll give us about 650 quality measures. So we generally take a subset of those quality measures and want to look at the adherence rate for the plan overall. So where do they compare to other plans, and how has their performance changed over time? Look at that on a county basis so we can see, are there counties where here in hemoglobin A1C, are there counties where adherence rates are lower than other portions of the state, where again, maybe there's a network issue, or there needs to be more outreach by the plan. And then finally here at a provider level, where we can look at individual providers and see how their performance compares to their peers. And again, use this in two ways, just a provider scorecard, show them that they're not performing according to your expectations, according to their peer group. And finally, we've also used this to work with providers and take one of these providers, drill into their patient panel and send letters to providers saying, you've got these 15 members in your panel that need a hemoglobin A1C test, so they can reach out directly to those members and try to improve, oversight and eliminate gaps in care for their population. So that's my last slide. So with that, are there any questions?
Thank you so much, Dr. Johnson. Really wonderful display of such rich information in your dashboards. We do have one Q&A that's come through.
Okay.
If people have others, please add them in. The question is, are the dashboards available publicly?
They're available to our clients. So, I mean, you could see some of those dashboards. We had individual members. We masked all the members' IDs and the provider IDs, but there's a lot of PHI and PII in those dashboards. So we have some COVID dashboards on other dashboards we've built using public information where there is no PHI or PII, but no, those dashboards get delivered to our health plan, and they use that to run their program.
Right, with the amount of rich drill-ins, I could definitely see why that wouldn't be the case. So I just have maybe one or two more questions that I had as you were doing your presentation. Because this is shared with the plans and there's such rich drill-ins, what is, since this is a presentation today on cost, what is one of the #1 ways you've seen the plan use your dashboards to contain costs?
Probably #1 is ED. I mean, that's, kind of lower hanging fruit, where if they know which hospitals have those large number of avoidable visits, you know, they can work with those hospitals to reduce that. Actually, one of the last conferences I was at, you know, talked to a couple of hospital staff whose goal was to do that, you know, to work with the practices whose members were frequent flyers at the ED to try to get them back into an office setting.
That's great. And then once a cohort of patients or groups of patients that have been identified as targets for some of the cost saving measures, is there a way in the dashboards to watch them separately?
Yes, I mean, we update those dashboards quarterly, so you can kind of track a member over time and see how their performance has changed. I mean, one of the you know, stories with the dashboard is we did look at that opioid dashboard and found a poor young woman who went to the ED 350 times. And then as we drilled into her disease conditions, found out that she had sickle cell. And the plan had a sickle cell care management, disease management program, and she wasn't enrolled. So they were able to kind of identify an opportunity there, really to improve the quality of her life so that she didn't end up in the ED every day.
Wow, it's very powerful. Well, thank you so much.
All right, thank you.
So we're going to move to our second presentation. I'd like to welcome Joel Ario, the Managing Director of Manatt Health, and Kevin McAvey, a Senior Manager at Manatt Health. Joel has spent the past 30 years shaping and implementing public health policy at the state and federal level, providing strategic consulting and analysis on healthcare policies and institutions, with an emphasis on the evolving role of health insurers in delivering public and commercial coverage under various regulatory frameworks. His extensive experience includes serving as the director of the Office of Health Insurance Exchange at the U.S. Department of Health and Human Services, and Joel currently serves as an advisor to the Robert Wood Johnson Foundation in support of its work with states, and has written extensively on the 1332 state innovation waivers. Joining today's presentation is his colleague Kevin. Kevin partners with state and health systems across the country to develop and implement data strategies that connect policy, program, and clinical decision-making to the best practice, to the best available public and private data and analytic resources. Please welcome Joel to kick off today's presentation.
Thanks, Leanne. And Kevin, you can move right to the agenda slide. Next slide. That was a fascinating presentation on some of the kind of a deep dive on some of the dynamics of hospital spending. We're going to take the focus up much broader now to the landscape of state policymaking, look at what states are doing to address the cost issues that bedevil us all these days, and then focus on one particular strategy, benchmarking or setting a cost growth target. I'm going to start with some broad context for why the states have landed on benchmarking. Kevin's then going to drill down on some of the program elements that are involved in such programs. Then we're both going to comment at the end a little bit on kind of key considerations for states that may be considering these programs. Those of you who aren't familiar with this area, the states that are kind of leading the way are Massachusetts, adopted a program back in 2012. Then Rhode Island and Delaware have programs. The next wave of states coming online now are Oregon, Washington, and Connecticut. And then there's a slew of states that are considering benchmarking programs: Colorado, Pennsylvania, California, Minnesota. I won't go on. I'm probably going to start missing some, but it's a broad kind of trend among the states these days. So we move to slide 4, Kevin, is the kind of, we've seen a real sea change in the last few years from really focused on access coming out of the ACA in 2010 and then the exchanges in 2014, where a lot of the focus of states and the federal government, for that matter, was on increasing access to coverage. But we're now back in a part of where the pendulum's shifting back to the question of affordability of coverage, because it's kind of constraining the ability to continue to build access. You see in the chart here that premiums have more than double, increased more than twice as fast as the growth in the wage index, and deductibles and other forms of cost sharing 4 times the rate of growth in wages. So clearly it's a problem that needs to be addressed. Those trends cannot be sustained. And in addition to being very hard on consumers and making access issues more difficult, it's also at a macro level, you know, causing Medicaid programs and other kind of health spending to squeeze out other state priorities. Next slide. This kind of shows how states have been successful in this period from the start of the ACA to today in cutting the number of uninsured. Many states now have uninsured rates below 10%. In fact, almost all states, except the ones that haven't expanded Medicaid, are well below 10%. And the federal government's been a big partner in that with the subsidies and guaranteed issue of coverage and other important federal reforms that were part of the ACA. Federal government hasn't been as good a partner in terms of cost control initiatives. There have been some limited payment reform models through CMMI that have been important and have potential and may turn out to be game changers. They really haven't been yet. And then other kind of more specific efforts. We know Congress is today even having trouble dealing with a relatively focused issue of surprise billing and what happens to people who end up with hospital bills out of network that they didn't expect to get. Even that problem has kind of made it not been solved yet at a federal level. Those states have a lot of different proposals on it, and so we're probably in a period where the states are going to be the most promising arena for innovation. Depends obviously somewhat on the next election, but most likely the states are still going to be the laboratories here for innovation. Next slide. There are different ways the states look at this. We kind of have this divided into targeted cost control, where you look at hospital pricing. A lot of states have looked at reference pricing, looking at the Medicare rates for hospitals, and then seeing that on the employer-based side, maybe twice, maybe three times those rates on average in some states. Not a lot of progress in that area, but definitely a lot of transparency efforts and efforts to sort of shine a light on hospital pricing, as Steve was showing us in the last presentation. Drug pricing the same way. There are now drug affordability boards in like a dozen states, and other strategies to try to crack the nut of drug pricing. The president's doing some on the federal level as well. And then all claims databases, kind of transparency strategies, get increasingly collect data, try to look at cost variation, identify cost outliers. On the systemic side, obviously antitrust enforcement continues to be an important area, although we continue to see consolidation, particularly on the provider side. That usually begets more consolidation on the insurer side. And so maybe coming out of COVID, now we're going to see even more of those trends. So there'll be many people calling for more vigorous antitrust enforcement. Sometimes works, sometimes does not. Hospital rate setting, a relatively unique strategy that Maryland kind of pioneered, but for some unique reasons, probably not the strategy that a lot of states are going to be able to pick up in the next few years. Medicaid buy-in, public option proposals at the state level, kind of potentially being harbingers of what could happen at the federal level on that issue. And then finally, the cost growth benchmarking that we're going to talk about more today. And you see there, Manatt has a report out kind of that drills deep on that for people who aren't familiar and haven't seen these issues yet. There's that Manatt resource that looks at the Massachusetts and California programs. And Kevin's going to now dig deeper into that in the next few slides.
Sounds good. Thank you, Joel, and thank you all for joining us. I have 4 or 5 minutes here to talk through the next few slides, and for those of you who know me know how hard that is. But I just want to say it's so good to see you, so many friends and colleagues on the participant list today. And while we only have a couple minutes to talk about the benchmarking programs today, we're happy to follow up offline. So over the past few years, Joel and I have been working with many states across the country to not only think about how they can use the existing data they have to inform their program and policy goals, but how they can set up new data infrastructure to inform their goals going forward. At the top of that list, and really near and dear to my heart, coming from Massachusetts and our fine colleagues at CHIA and HPC, has been the cost drivers programs and the benchmarking programs. Massachusetts initiated theirs in 2012 amidst a high cost environment, and every indication coming out of the state from studies and from many smart scholars over at local universities and Harvard and MIT only just emphasize how much of an impact the effect of having oversight in this way has had on cost growth in the Commonwealth. Other states like Rhode Island and Delaware took a little bit more of a lighter approach, but did what they could in the time that they had, implementing benchmarking programs in their respective smaller states. And Oregon is now taking a more robust approach, building on a long history of hospital and drug transparency. Again, we have plenty of information on each of these programs. If you just Google one of our last names and benchmarking, you'll see a couple of papers come up that explain how states have approached implementing their benchmarking programs in the past, as well as some considerations going forward. Some of the themes from our previous work include differentiation and considerations for other states going forward, really understanding their local market's needs. Every market is different, have different concentrations of payers and providers, and tailoring your own benchmarking program to capture those dynamics will be really important. States also differ in how and the resources that they have available, the governance structure, and who they really need to and want to bring into the fold to really discuss the infrastructure they'd like to have in place, the reporting they think is going to be most used and useful in the market, the types of supplemental data collection that they want paired with their cost-driving programs. So, for example, you might be collecting, as in Massachusetts, TME or expenses for various services that are by various populations. But you might want to pair that with other contextual reporting around premiums or cost sharing or value-based payments, APM reporting, and really thinking through those questions up front can result in a program that's more customized and appropriate for your state and its needs. As we think about what states, and I think there are some on this call really thinking about what should they be considering as they invest in a potential benchmarking program. On top of my list, I'm completely going off my notes here, regulatory authority, what do you have the authority to collect? What new authority might you need, as particularly and as connected to the uses of your data? How you want to use it should drive the data collection process you need. Really making sure you have broad buy-in and have for developing a culture of transparency and accountability. And then when you start to get towards operations and really thinking through the data you want to collect, have strong, respectful partnerships. I mean, I saw Bernie, among other friends on this call, really working with payers who are going to, this is not their day job to just do reporting, to really help explain what this data should be used for and wants to be, how it will advance everyone's causes. Were some of the important lessons learned when we were setting up the benchmarking program in Massachusetts and that other states have found valuable. Keeping the reporting infrastructure insulated also helps to preserve the integrity of the process and the outputs of that process, and making sure that you have dedicated staff and analytic capacity to maintain the data collection and reporting process from start to finish. Again, when you're thinking about setting up a benchmarking program, always please start with goals, like what you're hoping to achieve, and then let that drive the rest of the process, including what new authorities you might need, the types of data that you want to collect. And then when you think about the types of data, think about it within the basket of data assets that you might have available. APCDs, discharge data, patient event notifications, ADT data. And a lot of our friends on this call have access to more data than we often think we do, and really thinking about how you can bring those assets in to provide the context you're looking for, get as close as possible to the information you want to derive from the data collection is really valuable. I always come back to the analogy of I view cost benchmarking reporting as a state taking a full body scan of itself. It will tell you where there are problem areas, like your liver is failing, but then to the extent you have an APCD, you can actually use that data asset to test the liver and what's wrong with it, really dive down into what are the, for instance, pharmaceutical drug costs, like pharmaceutical drugs that are driving the cost trends in that service category. You can use the programs you set up to also centralize a lot of existing data collection and reporting you might have in place, and then focus attention on action. And then the final thing I'll say here before passing it on to Joel is, I've been asked, and we've been engaging clients around 3 questions about the future of cost benchmarking reporting for those states that have programs in place right now or are in the process of it. Like thinking about, like, so we have the car, like where do we drive it now? How can we build on the existing infrastructure? Think about cost burden and state cost burden and other healthcare priorities like primary care and behavioral health, substance use disorder, and the spending that goes to those priorities. Health equity, where we've been developing ways to use and develop cost drivers reporting that go to illuminate answers to some of those pressing questions. And then, of course, like, how do we deal with data from 2020? But Joel, to close us up, I'll pass it back to you with a few closing thoughts.
Sure. Thanks, Kevin. These time constraints are brutal for Kevin and I, who obviously always like to share a lot more than we have time to share. I'm going to just focus on one issue, data standardization here, or standardization more generally about the benchmarking programs. I spent most of my career at the state level in health policy, and I know that as you start developing programs, you have a tendency to want to, elaborate on them and have unique state features to them, and that all is very important, and many of the things going on in the more mature state benchmarking programs go in that direction, adding additional data beyond the kind of basic provider payer data that you build the program around. But standardization is going to, I think, be an important issue, and not just for benchmarking programs, but also for APCDs and other state efforts to collect data for several reasons. One, you have more payer opposition when each state is reinventing the wheel and creating new programs, particularly from the national insurers, who still hold a sizable market share in most states. And so it just becomes more efficient to have a more common approach to things. Secondly, states can then share across state lines, and you can make more meaningful comparisons that way. And third, it does set up then, a national conversation that eventually most good state reforms get translated into some kind of new national policy. We have the ACA because we had the Massachusetts connector in the first place. So this is kind of a route to creating state experimentation, but then moving us to federal solutions where they're appropriate. So a lot of the work that Kevin and I are doing now, and we welcome anybody who's got thoughts and contributions on this to email to us, is trying to take those states that are developing these programs, create a baseline of replicable data collection and approaches, and then look for routes to make those things become national models that can make it even easier for other states to develop these programs in the future. With that, I'll turn it back to Leanne and questions.
Thank you so much, Kevin and Joel. You provided a great framework for states looking into benchmark programs and ways that they can be adapted to match new state priorities. Now, I haven't gotten any Q&As in yet from the audience. Please send them in, but I'll start with a couple questions that I had. Of all the resources needed for successful benchmarking programs, which do you see the states struggle with the most, and any tips from states that have been successful in that particular area?
Kevin, why don't you take that? Kevin?
Yeah, absolutely. I was just unmuting myself on multiple fronts. I'm also just realizing like my backdrop looks like a horror movie and I can't do anything about it. But anyway, I think that the most important ingredient for a successful benchmarking program, I'd actually just have to say, is broad stakeholder buy-in. This is a program that implicates everyone, both in its production as well as in its results, and really developing a culture of transparency and accountability and bringing everyone along with you, I think, is one of the most important, if not the most important ingredient. But Joel, anything else?
No, that's a good answer. I'm mindful of our time. I want to make sure we have time for that third presentation. But
Great, great. Okay, so thank you so much. We will pivot to the third and final presentation. So our final presentation is from Karla Lopez de Nava with the Lewin Group. Dr. Lopez de Nava has over 15 years of experience conducting quantitative analysis and policy research with a focus on CMS payments, policy and program evaluation. As part of the SIG multi-payer operations effort, Dr. Lopez de Nava currently leads a team of researchers in analyzing, monitoring Maryland's total cost of care model and care redesign program. As part of this project, she has been responsible for leading the development and validation of multi-payer payment methodologies. Please welcome Dr. Lopez de Nava.
Hi, good afternoon. I'm very glad to be here. And actually, this is a good follow-up from Joel's and Kevin's presentation, because today I'm going to be talking a little bit about Maryland's model, which is certainly and has been very innovative in trying to control costs. And in particular, I'm going to be discussing how the HSCRC all-payer case mix data allows the stakeholders as CMS and the Maryland state to assess the performance of their models. So the order of this presentation, I'm just going to be, as I mentioned, showcasing the usefulness of HSCRC case mix data to monitor, to help us assess the performance of Maryland's models. And I'm going to be providing very briefly a little bit of context of Maryland's unique healthcare system. Then I'm going to be discussing quickly a little bit of the data and the methods we use for this analysis, and then showcasing some of our key results. And then obviously answering any questions that might arise. So as probably most of you know, CMS in conjunction with the state of Maryland, or Maryland in conjunction with CMS, operates the total cost of care model, which encompasses a variety of care redesign programs that aim to contain costs and improve the quality of care of Marylanders. And as I mentioned, we're going to be showcasing how the Maryland all-payer case mix data allows us to CMS and allows CMS and the state first to monitor the performance of the model, and in particular ensure that the state is meeting the financial and quality of care targets that are outlined in the contract, in the waiver. It also allows us to assess variation in the performance across payers, between commercial and public payers, and also more importantly, it allows us ultimately to inform policy development, and I'm going to be discussing that a little bit more further on. But first, let me again just give a quick review of the Maryland healthcare model. And as Joel was mentioning, since the 1970s, Maryland has used an all-payer rate setting model, a hospital payment model. And this means that obviously all patients are charged the same amount for given hospital services, and the standard cost per admission is indexed to an all patients refined diagnosis-related group. This system certainly helped at some point contain costs because it sets the rates that are charged. However, it doesn't cap volume. And what happened is that volume of services started increasing. And by 2017, the Maryland per capita Medicare costs were among the highest in the nation, and the readmission rate for Medicare beneficiaries was 170% of the national average. So in 2014, Maryland and CMS enter into this new waiver called the all-payer model. And in this model, they maintain the all-payer rate, but then they imposed a hospital global budget. So basically, each hospital has a revenue limit, that annual revenue limit. And this model, which ran from 2014 and ended up a couple of years back, was very successful in containing growth in hospital costs, but it didn't focus on post-acute care services costs. So in 2019, Maryland and CMS again come up with a new waiver called the Maryland Total Cost of Care model. And this model expands the all-payer model, but also focuses on the coordination between hospital settings and post-acute care providers. And this is an 8-year model with a possibility of expansion depending on state performance. It's an advanced alternative payment model, and it encompasses 3 large programs. One is the hospital payment program, which is the one I'm going to be focusing about, which again is the all-payer model. It's the all-payer and global budget for hospitals. And then, but it now includes the Maryland Primary Care Program, which follows the CPC Plus program, the National CPC Plus program, and the Care Redesign Program, which encompasses a variety of tracks, models, and some of them which follow, for example, the bundle payments for care improvement initiatives, some models like that. So as you can see, Maryland has been at the forefront of innovation. And then I'm gonna be, and then one thing I want to mention is to maintain the total cost of care model waiver, CMS requires the state to meet certain financial and quality of care targets. And one of them, which is one that I'm gonna be talking about, is that the all-payer hospital revenue growth per capita, the annual, must not exceed the growth in the all-payer revenue growth cannot exceed 3.58% per year. It also requires Maryland to save $1 billion in cumulative annual Medicare savings by the end of 2023. And it also requires the state's quality programs to perform as well, if not better, than the Medicare national quality programs, like the hospital readmissions reduction program or the value-based programs, etc. So one thing that I want to mention is, before I move on, is, and again, these are the implications of policy, is that if the state does not meet some of these targets, what happens is what it's called a triggering event that can result in a multiple and a variety of corrective actions. You know, Maryland might, the state, if it doesn't meet some of these targets, then there can be, the state may be requested to pay more, to monitor more closely certain areas, or there can be modifications even in the waiver in the model. So again, I just want to highlight the importance of monitoring these targets and the impact that meeting them or not can have. So as I mentioned, obviously the data, we use HSCRC all-payer and counter-level data. This is referred to as the case mix data. And we use it from January 2013 through, our analysis covers 2013 to December 2019. And these data are abstracted from medical records. On average, annually, the state has around 600,000 inpatient discharges and about 5.5 million outpatient visits. Again, this is an average because these numbers change every year. And these data, these all-payer data, include demographic information, financial information, and clinical information. So they are extremely comprehensive and certainly very useful to monitor the model. So the methods we use, the total cost of care model and the former all-payer model outline in the waivers the methodology to measure financial targets, and we follow that methodology. And we also keep track of other financial and quality of care metrics, and we produce summary statistics and year-over-year growth rates and graphs and trends. And again, I'm just gonna be showcasing a couple of the measures that we monitor. And the first one, as I mentioned, which again is one of the key metrics stated in the waiver, is the annual all-payer hospital revenue per capita growth. And you can see in this table that Maryland has had a very, very good performance, except for 2017. Maryland kept to the 3.58% cap in growth, the all-payer. So in general, we've seen this certainly decrease or cap the revenue growth. So you can see that it's been successful for at least the majority of years. But then we can also see what has been happening to the total revenue and the breakdown between inpatient and outpatient. And one thing that we've seen is that both the total and per encounter inpatient and outpatient revenue has steadily grown over time. Again, the per capita has not managed to exceed the cap, but we have seen a steady increase, again, both in the totals and the per encounter. Here, this graph just is showcasing the total, not the per encounter, but if somebody's interested in seeing the numbers for the per encounter, I'm happy to share them post the meeting. We showcase here how the charge per admission and per visit has been increasing, because we know that although the total number of both admissions and outpatient encounters has decreased over time, the charge per encounter has increased steadily over time, and this is equal for both inpatient and outpatient encounters. We also observe the performance by payer, and here what you can see in these graphs is the inpatient admissions by payer type and the outpatient visits by payer type. And what you can see is that the biggest share of inpatient admissions is by beneficiaries that are covered by commercial insurance, and the smallest is by Medicare Advantage. And the same thing applies to outpatient care. But what is interesting is that, yeah, commercial beneficiaries covered by commercial insurance certainly present the biggest share, but the share of commercial insurance has been declining over time. The coverage by Medicare fee-for-service is close to the commercial coverage, and you can also see kind of a similar trend down in decline in the inpatient side. For the outpatient side, we can see that commercial certainly has the biggest share, and then Medicare and Medicaid MCOs are kind of following, but at a lower coverage. One of the things we observed, which is another target that is monitored both by CMS and the state of Maryland, is obviously the all-payer hospital readmissions and charges. And we've seen that the readmission rate for all-payer has decreased decreased from 2013 to 2017, but then we've seen again, an increase after 2017. It hasn't reached the levels of 2013, but it started increasing in subsequent years. And again, the charge per readmission, you can see that certainly it has been growing. And these are the hospital readmission rates by payer. And you can see that perhaps not surprisingly to some of you, is that the Medicare and Medicaid eligible present the highest readmission rates. And I'm sorry here, I don't know what happened, but the commercial payers, beneficiaries covered by commercial present the lower hospital readmission rates. And you can see that they have been moving kind of very similar, like the payers in this particular measure have been, their share is different, but the movements have been quite similar. Again, decreases for most of them up until 2017, and some increases post 2017. We also measure hospital acquired conditions for the all payer population. And again, you see fluctuations over time. The percent of admissions with hack events decreased up until 2016, but then jumped back to 2000, post 2016. And again, we're close to 2013 numbers. And not surprisingly, expenditures per hack event have continued to increase steadily over these years. And here we have a graph that shows us the expenditures for a hack event, but by payer time and by payer type. And you can see that although you know, it has increased. Expenditures per hack event have increased, and you can see that here, kind of if you take the whole bar. But they have certainly fluctuated across payers. You can see that sometimes, for example, the Medicaid managed care had a bigger share in 2013, then it saw decreases in 2014, 2015, 2016, and then it again increased and jumped. So you can also see that for other payers, and again, there's a lot of fluctuation over time across payers, although overall expenditures per hack event have increased over time. And again, I hope the graphs that I showed you showcase how useful and important the all-payer data is, and again, the impact, because it allows us to measure the financial and quality of the model, the performance of the model. And again, it's key in the sense that it allows both the state of Maryland and CMS to at some point change course if necessary, if some of these targets are not being met. So with that, I'll pass the microphone to you, Leanne.
Thank you so much, Karla. For that was really wonderful seeing all the work going on in Maryland with the program redesign to contain costs and improve care. They really are at the forefront of innovation. So I have not gotten any particular questions in, and I know we only have a couple moments left in today's presentation. So maybe I'll just throw one quick question out to the group, and then do a wrap up. So in our 1 minute wrap up, since today's session is entitled Benchmarking Past, Present, and Future, what do you see as the one biggest factor in being able to better use data to contain costs in the future? I know that's probably a hard question. Joel, do you want to go first?
Yeah, I think to be able to do it effectively, we're going to have to both have experimentation at the state level and a concerted effort to bring some consistency to that across states, because I think some of the stakeholder issues that Kevin referenced are going to be much easier to accomplish if this is done in an overall standardization framework, not every state on its own kind of framework.
Great. Thanks, Joel. Steve, do you want to go next? Can't hear you, Steve.
I think just getting the data organized, getting the data, ingested, cleaned up, validated, so that people, believe your results are credible. And then, the ability to have the staff to do the analytics. A lot of states are starting to, experience challenges with the retirements and just kind of lost that institutional knowledge.
Great. Thanks, Steve. Karla, do you want to go next?
Yeah, I think something that Kevin and Joel brought up, and I think Maryland is a special case because, again, they have been doing this since 1970, so they have a very good platform and buy-in, but the buy-in of the payers, of everyone, of sharing the data. I think that's one of the hardest, the biggest obstacles, and you can see it here in California, and you can see it in other states. I think just getting the buy-in and the trust of sharing the data.
Great, thanks so much, Karla. And Kevin, last but not least.
Thank you so much. So the only thing I would add, and I just want to also say, Steve and Karla, it was great to see your presentation. Thank you so much for taking the time. I learned a lot already. Is incrementalism. I mean, just because you see some of these benchmarking programs, it might seem intimidating to set such an infrastructure up at first, but you don't have to go full-fledged. And the states that do have it didn't go all the way to start. And I think it's just a matter of taking those steps to create a culture of transparency and accountability and collect, as Steve said, the right data to inform your use cases. I think that's a takeaway, at least for me, always in these conversations.
Great, thank you. This has been a really wonderful session. I really enjoyed working with this whole panel. And in the interest of ending on time, Charles, is there anything we should do to wrap up today's session?
Let me just say thank you to all of you, the presenters, to you, Leanne, as the moderator, also to Peterson Center for Health for being a sponsor. Visit the exhibit hall. There's a session survey and Excel events, and there's a workshop sign up for innovative analytics and multi-state collaboration. Other than that, the Elliott Stone Award is being presented in another channel right now. So I'll see you over there.
Thank you. Thanks, everyone. It's been great.